Okay. All right. So today I'm going to talk about some of my work that I've done during my PhD on building AI tools for clinicians' decision making. Um, Feel free to ask questions throughout. So this should be like a 45-minute talk, but please ask questions throughout if there's anything that doesn't make any sense. I'm assuming a lot of the audience has like a machine learning background, but if not, I'll give some details and then please ask any clarifying questions that you might have. Okay, so before I talk about any of the healthcare work that I've worked on, I'm actually going to talk about something that is on everybody's minds these days, which isn't health, and that's ChatGPT. So ChatGPT came out a couple years ago, and it kind of took the world by storm. And everyone was really excited about it, but it also came with limitations. So I'm going to walk through kind of an example of a prompt to ChatGPT. So the chief ethics officer, Margaret Mitchell at Hugging Face, asked ChatGPT in this sentence, the professor told the graduate student she wasn't working hard enough, who wasn't working hard enough. And ChatGPT's response to this was, in this sentence, she refers to the grad student. So the grad student is the one who the professor believes wasn't working hard enough. Okay, that seems like a reasonable answer. And then Margaret prompted ChatGPT again, and she said, okay, in the sentence, the professor told the graduate student he wasn't working hard enough, who wasn't working hard enough. And so the only thing here that changed was he or she was in the first sentence, he is in the second sentence. And ChatGPT's response to this was the pronoun he refers to the professor. So what happened here? In the first sentence, the pronoun she could not refer to the professor, but in the second sentence, the pronoun he could. And so ChatGPT kind of ties itself into a knot to avoid women being professors in its response. So this is somewhat problematic. This is kind of seen throughout ChatGPT in many different examples. And this isn't just an example of bias. So the model itself was biased because all of the training data that OpenAI trained it on was also biased. And that's kind of the central theme of my work. So while ChatGPT is biased, healthcare also isn't immune to bias. So we know healthcare is biased in many different ways. For example, in heart disease diagnosis, women are much less likely to be diagnosed correctly for their conditions compared to men. And then when patients have their pulse ox measured, so when you put a pulse oximeter on patients, it actually does worse on darker skin patients compared to lighter skin patients. So it's just less accurate for anyone who has darker skin, and thus could result in misdiagnoses if clinicians don't have the right data to make their decisions. And so these biases, because we're collecting all this data and using them to train models, they exist in the training data that we use to train our AI models on. And because of this, AI models could rely on the biases and reproduce or exacerbate them when ultimately helping clinicians make diagnostic decisions. In my talk, I'm going to talk about how mitigating this bias and thus making AI models better for all patients requires both computational and human-in-the-loop approaches. Okay, so specifically in my work, I focus on the condition of acute respiratory failure, and this is when a patient presents with shortness of breath to the hospital and requires mechanical ventilation, and a doctor needs to make a diagnosis. So about 3 million patients in the US and significantly more worldwide are hospitalized for this condition every year. And it comes with associated costs of about $54 billion in the US, and I think it's close to 1 trillion worldwide. And the condition itself has a significantly high mortality rate. So about 20% of patients who enter the hospital with the condition will probably die from the condition. And so diagnosing the cause of acute respiratory failure, as alluded to by the high mortality rate, is actually very difficult. So a clinician will typically take a look at many different data types to make the diagnosis, the patient's chest x-ray, their history, their lab results, any prior hospitalizations, et cetera, really any information that's available to them. And their goal is to differentiate between 3 different common causes of respiratory failure with 3 very different treatments. So pneumonia is treated with antibiotics because pneumonia is an infection of the lungs. Heart failure is treated with diuretics because typically with heart failure, you retain a lot of water, and the goal of the diuretics is to remove that water. And chronic obstructive pulmonary disease, or COPD, is treated with steroids because COPD is characterized by hyperinflated lungs, and steroids typically bring down inflammation in the body. And about 30% of patients actually receive incorrect initial treatment. So doctors will get this diagnosis wrong the first time for about 30% of patients. And this is really bad because if you give the patients incorrect initial treatment, you prevent them from being able to heal from whatever is causing the respiratory failure. And then two, you might actually exacerbate what's causing the respiratory failure. So for example, if a patient has pneumonia and they need antibiotics for the infection, but you give them steroids, you've now suppressed their immune system and they can no longer fight off the infection that's actually causing their respiratory failure. So some example complications of this condition are organ failure or sepsis, and even death, like I mentioned. So this is a very difficult diagnosis. And the goal of my work is to try to help clinicians come to better treatment decisions quicker. And so this gives us an opportunity to develop AI tools for acute respiratory failure. So in some of my early work, we focused on developing an AI model. So this AI model took in one of the patient's chest x-rays at respiratory failure diagnosis, as well as a subset of their clinical data. So we had about 60 clinical variables that the model saw. And then we trained a deep learning model, which then output 3 different probabilities, all corresponding to the likelihood that the patient had each of the 3 conditions. And you'll notice that these don't actually sum up to 1. So the patient could have any combination of the 3 conditions or not at all. So we treated them as 3 separate tasks for the network. And we trained this model on 1,200 patients hospitalized with respiratory failure at Michigan Medicine, which is the hospital associated with my school. And for each of these patients, we had up to 4 clinicians label each of the patients for whatever was causing the respiratory failure. So that's what we used as ground truth to make these predictions. And these physicians had access to, again, the entirety of the patient chart, any prior hospitalizations, and their responses to treatments to give us these labels. We measured model performance in terms of the area under the receiver operating characteristic curve. And this is just what is the likelihood that a model will rank a randomly selected patient with the disease higher than a randomly selected patient without the disease. So our goal here is 1, and our baseline is 50%, or 0.5, because that's just a random coin flip. And then, so we measured AUROC with respect to each of the 3 diagnoses, and we compared to a randomly selected physician. So we asked, like, how well do clinicians do at this task? Randomly selected physicians do somewhere between 0.75 and 0.78 AUROC, which is pretty good, and also correlates with what we saw in the literature, which is they're not perfect, but they do better than chance. And our model actually did just as well, or even better, significantly better in terms of COPD in making this diagnosis compared to a randomly selected physician. So this was really promising that the model did just as well or better, but with significantly less information. So I mentioned the model only had access to 1 chest x-ray and just a subset of their clinical data. Physicians had access to significantly more, so the entirety of the patient's hospitalization to make the decision. So that's really promising. We want AI models to do really well. Like, we're never going to deploy an AI model that does poorly. But then we were also skeptical. We were like, why is the AI model doing so well when it has significantly less information to make this very difficult diagnosis? And so then we started to dig into, like, how is the model making its decisions? Specifically, when we have images, here we have x-rays. In computer vision, we have a tool called GradCam, and this tool lets us ask the question, what is the model looking at in this image to classify the specific patient? So we have the image, and GradCam creates this heat map based on the network that we trained, and yellow and blue areas of the heat map basically tell us where is the model paying attention to. So for this patient with congestive heart failure, it seems like the model is paying attention to the areas around the heart, which is promising. This is what our clinical collaborators would expect. But then the model actually also pays attention to the fact that the patient has a pacemaker. So if you squint your eyes and look really closely, the model is slightly focused on the presence of the pacemaker. And so when we asked our clinical collaborators, does this make sense to you? Should the model be looking at the pacemaker? Their answer was no. We don't want the model looking at the pacemaker, because if the pacemaker wasn't there for this patient, the patient would still have heart failure. Like the presence of this pacemaker does not affect whether or not we find things like edema on the chest X-ray or an enlarged heart. So this isn't great. This is not what we want the model to do, but this is an example of the model taking a shortcut. So what do I mean by shortcut? So models, let's say, basically pay attention to things on the image that they shouldn't. And so here's like a general computer vision example. Let's say we wanted to train a system that takes in images of cows and classifies whether or not a cow exists on the image. So we collect all the cow images on the internet, and we train the system, and it does really well. So it has perfect accuracy, and this is really promising. And then we give the model a new image of a cow. And this new cow, for this image specifically, the model actually says that the image doesn't have a cow. And so this is confusing. But if you look at the difference between the left-hand side and the right-hand side, all the cows that we trained the model on were sitting on green grassy backgrounds. So instead of learning what makes a cow, the model said, well, if I see a green grassy background, then this must be a cow. And so when it saw a cow on the beach, it said there must be no cow in this image. And so basically what happened here was the model capitalized on a correlation in the data rather than focusing on what actually makes a cow a cow. And this is basically what we were seeing in the chest X-rays. So it turns out that you can easily infer many different attributes based on chest X-rays that are not related to disease. And so in some of our other work, we asked how easy is it to infer different attributes based on chest X-rays alone. So we trained models to predict different attributes. In addition to being able to detect a pacemaker very easily, the model could learn the patient's sex. It can learn the patient's BMI or body mass index, which is just how much body fat does this patient have. It could learn the patient's age pretty well. And it could also learn the patient's rates with some signal. It didn't do very well on our small cohort of 1,200 patients. But then some follow-up work showed that if you have enough data, so a later work looked at over 200,000 chest X-rays, you could actually predict the patient's race pretty accurately just from the black and white chest X-ray. So in addition to deciphering what looks like disease on an X-ray, a model could actually also look at all these other things on the X-ray that we might not want it to look at. But specifically what makes an attribute a shortcut, you can learn a bunch of different things on an X-ray. There are specific criteria. So a shortcut is, first, there has to be a spurious correlation in the AI model's training data. So if there is no correlation between pacemaker and heart failure, the model won't pay attention to it. But then also, this attribute has to be easily exploited. So it has to be easier to learn compared to clinically relevant features of disease. So for example, if there's a spurious correlation between pacemaker and heart failure, and it's easier to learn the presence of a pacemaker rather than an enlarged heart, which is typically what clinicians look for in heart failure, then the model is going to fail when, let's say, the prevalence of pacemakers change, or they look different in new patient populations, or we stop using pacemakers in this patient population. But alternatively, what doesn't change is what does heart failure look like? So that's the case when the model is going to fail. Okay, so to combat this, we focused on trying to develop computational approaches to shortcut mitigation. And one of these is based on a transfer learning approach. So let's say we want to predict congestive heart failure from the patient's chest X-ray, but we happen to have a data set where there is a one-to-one correlation between the presence of heart failure, the diagnosis of heart failure and the presence of a patient's pacemaker. So every single patient in our data set that had heart failure also had a pacemaker. And then let's say we had some test data where this correlation breaks. So there is no correlation between the presence of a pacemaker and the patient's diagnosis of heart failure. And so using standard approaches, let's say we train a deep neural network where we have some encoder E that learns features of chest X-rays, and then a classifier F that classifies the patient's heart failure based on those features. Training this model end-to-end, so learning all parameters of the network, theta, which parameterize the encoder, and W, which parameterize the classifier. The model will just capitalize on the features of pacemakers via W when predicting heart failure. So training that network end-to-end just isn't going to work because we're allowing the model to learn the features of pacemakers. Instead, what we proposed was maybe we could use a transfer learning approach to circumvent the model learning the features of a pacemaker. And so what I mean by this is, let's say we have some unbiased source tasks. So we have a related data set. It's not heart failure, but maybe it's labeled for pneumonia. And in this data set, there is no correlation between pneumonia and the pacemaker. So if we first train a network to predict pneumonia, so again, we learn the encoder parameterized by theta, the features, and then we learn some classifier on top of those features, and we predict pneumonia. We can then transfer those learned features to predict heart failure. So instead, we hypothesized that the chest X-ray features used to predict the unbiased source task pneumonia could also be used to predict the biased target task. So we take this network and then we freeze the encoder. So we drop the classifier that we learned. We freeze the encoder, and then we only learn the classifier weights on the biased target task. So again, we've cut the ability of the network to learn features of pacemakers by first pre-training it on some related task where pacemakers are not important. So here the idea again is that the model just cannot leverage the features of pacemaker during classification because it just never learned them. And it turns out that this actually does pretty well. So again, remember our goal is to predict congestive heart failure. We have this biased training data and then an unbiased test data. And we tested this across many different attributes. So, across age, patient sex, patient's BMI, and whether or not a pacemaker is present. If you train the network end to end, the model does pretty poorly. So here, our baseline network where we train end to end, it does almost random in our test data because it just fails. It capitalized on this spurious correlation. But then using the proposed approach, we actually improve model performance significantly. So the model does significantly better because it doesn't capitalize on these shortcuts. So that's really good. This is like ideally we'd be able to do this across all shortcuts, but this method comes with limitations. So it requires knowing this bias in advance. Many biases are hard to detect. So it actually took a long time, maybe like 2 years after our work, where people showed that you could actually predict race from the patient's chest X-ray, and there might be a bunch of other things the network could learn. It also requires access to a source data set. So labeling data can be very expensive and time consuming. And so putting in the effort to collect the source data set is going to be costly. And it only works on one bias at a time. So if the model leverages multiple shortcuts, we'd have to debias a source data set on many different shortcuts. And again, this costs time and money. So basically, there's no silver bullet. We need more than computational approaches to mitigate this problem. And that kind of gets me into our hypothesis, which was maybe a human-in-the-loop approach could help us mitigate bias. So if you recall, I showed you this GradCam heat map of the chest X-ray earlier. And when we were developing the model, we noticed that the model was paying attention to something it shouldn't. So we thought maybe clinicians could do that at the bedside as well. And this gets me into the era of explainable AI. So explainable AI tries to address this black box problem. So deep neural networks are very large AI models because of their complex nature. It's just difficult for humans to understand how AI models reach their conclusions. And the goal of explainable AI is to try and make the reasons behind these AI model decisions comprehensible to humans. And that's what we saw with the heat map explanation. And some of the goals might be, try to make AI more transparent or understandable or trustworthy. And these are all like very lofty goals. But the problem is that it's actually largely debated whether this is actually useful to end users. So we don't know if end users can actually leverage explainable AI very well. And some, in terms of the debate, some are very pro explainable AI. So, it's been suggested by some as a tool to help end users perform better with AI and expose problematic behavior. So hopefully clinicians will, do better with AI. And there was one study that showed that if they gave users an AI model that took a shortcut, and then also gave the users the explanation for the AI model, they noticed that it was unexpected. So they noticed that the model was paying attention to something it shouldn't. And others are very excited about AI in radiology. So they've argued that with help of interpretability methods, the next generation of radiology will likely experience full use and enhanced trust in AI and deep learning. So others like doctors and radiologists are very excited about this field. On the other hand, there are some cons. So there are concerns that explainability approaches could cause problems during decision making. And there was this study that looked at if you gave users or clinicians an AI model to help them make treatment choices for major depressive disorder, if you also gave them the explanation for the AI, it actually made the users worse when the AI was wrong. So the users just over relied on the AI when given the explanation. So the community is a little bit split. But for now, it seems like the FDA in the US, in terms of regulating AI, is on the side of explainability. So in some recent regulatory proposals, the FDA has decided or proposes that in terms of regulating AI, explanations could be a way for them to circumvent the regulation. So if you basically give a clinician an AI's explanation such that it enables the clinician to review the basis for the AI recommendation, then the FDA will not regulate the AI device as a clinical decision support software. So if the user can basically make decisions on their own based on the AI explanations, the FDA just won't regulate the device. The problem is, to date, this approach has not been tested. So even though it's been proposed as policy, and this is not just in the US, there's also the EU has been focused on this. The problem is that clinician AI interaction studies to support these policies are just lacking. We don't know how they actually interact with AI explanations. So we sought to test this. We sought to ask the question, can explanations help end users? And our hypothesis was that real-time local explanations, which I'll explain what that actually means, can help clinicians discern good model advice from bad model advice. And so good model advice might look like something like this, where a model given a chest x-ray pays attention to the lung area, and this is what aligns with clinical intuition when they look at a chest x-ray. Bad model advice might look like this. The model pays attention to something like the shoulder. Here, the model is focused on the patient age. Something about the shoulder blade is indicative of whatever age the patient is. And here the model is paying attention to, like, it's completely unrelated to the lung region. And hopefully, if a clinician saw something like this, they just wouldn't pay attention to the AI's advice. And the reason we used GradCam specifically is that it's a widely used explanation method for deep learning models. So the paper itself has over 17,000 citations. We use it all the time to debug our models during development. And even in the paper, they claim that through extensive human studies, they reveal that their visualizations can help identify biases in data sets. So they even did some testing with GradCam and said, we can catch biases in our data. The question is, can we catch biases in chest x-rays with it? So our approach was a web-based clinical vignette survey study in which participants were presented with clinical vignettes of patients hospitalized with acute respiratory failure. So these were real patients from Michigan Medicine, and we gave real AI advice in this web-based survey. So I mentioned local explanations. What are local explanations? When we train models on images, we actually don't have any tools to understand overall model behavior. So we don't know in general how the model behaves. We can only understand how the model makes a decision based on each image instance alone. So for example, we can generate this GradCam for every single image that the model sees during development, and then during deployment, as the model is making predictions based on chest x-rays, we can keep generating these GradCams and see what the model is paying attention to. So again, here the model is saying the model pays attention to the areas highlighted in yellow when making a diagnostic prediction for this patient. And we can generate this explanation for every single patient that the AI sees at deployment. In terms of the study setup, so each patient came with a patient vignette, and this included a real patient case. It included their history, their laboratory results, and their chest x-ray at the time of diagnosis. And then we asked participants to rate the likelihood that each of the three conditions I mentioned, pneumonia, heart failure, and COPD, contributed to the patient's respiratory failure. And here it was on a scale of 0 to 100, and we told them it could be any combination of the three or none at all. So again, these don't have to add up to 100%. And then in addition to this, we also asked them which treatment they would administer to the patient given the diagnosis that they just gave. So here, these are three very common treatments for the patient. And if they decided, hey, this patient doesn't have any of these conditions, they could also choose not to treat. In terms of the model that we use, the model had to behave in a specific way across the patient population. So we had a total of 45 patients in the study. And overall, we had a model that performed reasonably. So this kind of mimics what we might have during deployment. We've trained a model, it does pretty well. We don't know that it actually does a little bit worse on some patients, but overall, it seems like the model is doing pretty well. So we have, for the majority, some standard predictions. Here, the model had about 76% accuracy. And then for a very small subset of patients, the model takes a shortcut and fails. So it's kind of hidden. It's hard to detect all biases again during development. So here we simulated an environment where the model just fails in a small subset of the patient population, and it's hard to detect before we actually deploy the model. In terms of what the AI model input looked like, we had an algorithm. We told them an algorithm is applied to the patient's vitals, their labs, and their chest x-ray, and it estimates how likely the patient's current symptoms are due to each of the three diagnoses. And then if the model predicted that the patient did have the diagnosis here, in the case of pneumonia, because it gave a score of 60, we showed them the grad camp. So we said, here are the locations that the model is looking at when identifying pneumonia. So that's how the AI model looked like for them. And then in terms of the randomization, so we randomized patients to different settings to be able to test different ways of presenting the AI model. So for the first two vignettes, this was 2 total patients, all participants had no model assistance. So we just wanted to ask how well do they do at baseline without any AI input. And then we randomized to see either AI model predictions alone or AI model predictions with explanations. And the goal is to compare across the 2 groups and see how the explanations affect their performance. And so that was a total of 6 vignettes. And within those 6 vignettes, they saw 3 standard model vignettes. Again, these are AI models that do reasonably well and look at reasonable areas on the chest x-ray. And then they saw 3 biased model vignettes. And here the AI model did very poorly and looked at the wrong areas of the chest x-ray. And for those 6, we randomized the order so that we wouldn't bias them towards one specific type of model versus another. So what do we expect in terms of results? Here's what our hope was in terms of the study outcome. So we showed participants very overtly biased explanations. And what I mean by this is, like, again, our standard explanations look at some reasonable areas on the chest x-rays, but the bias explanations look completely outside the lung region. And the hope here is that if the clinicians can catch the model bias when it's paying attention to something so like overtly biased, then maybe we have some hope when the bias is more subtle. But if they can't even catch the bias in this case, then they probably aren't going to catch more subtle biases either. So again, we expect the clinicians to ignore the bias model predictions when presented with these bias explanations and hopefully recover to their baseline performance. So just ignore the model, make a decision on your own. In terms of evaluation, so the reference label we had, and this was just what we used for ground truth, for each of the 45 patients, we had 4 or more pulmonary physicians independently review each patient's complete medical record, and this gave us a determination of what was causing their respiratory failure and what was the patient's underlying diagnosis. And then they also took a look at what treatment should we give the patient. The primary outcome of the study was the participants' diagnostic accuracy on the patients, and this was considered correct if the participants' response or assessment agreed with the reference label that we had. And then the secondary outcome for the study was their treatment accuracy. So this was considered correct if the participants' treatment choice agreed with what was administered to the patient during hospitalization. Okay, so in terms of results, over a 7-month period, we surveyed participants across 14 states and 14 different hospital systems in the US. And we had a 572 participant responses, 418 of which completed all of the vignettes in the study. Of these, 284 participants saw the AI model alone, and then 288 participants saw the AI model with corresponding explanations. And about 98% of participants practiced hospital medicine. So this was really important because hospital medicine physicians or hospitalists are those who are taking care of acute respiratory failure patients all the time. They are the experts at this diagnosis. It's not just a random medical student taking the survey or someone who doesn't have much experience making these diagnoses. So that was really good. That was our target audience for this study. Okay, so how do participants do? First, we looked at, again, clinicians' diagnostic accuracy in different settings. The clinicians alone had about 73% accuracy in making the diagnoses. So this was promising because this is what agreed with the literature I mentioned before. Up to 30% of patients receive incorrect initial treatment. And then when given standard model predictions, clinicians made better diagnostic decisions. So this is, again, promising. The standard model wasn't perfect. It had about 76% accuracy, but with the standard model, clinicians did do better. And then when given standard model predictions with explanations, explanations just amplified this effect. So we reached almost 78% accuracy, and comparatively to their baseline, a 5% increase in accuracy is actually really good. Like we don't have much room to grow. So 5% is very clinically relevant here. So this is promising. This is what we'd want to see when we actually deploy an AI model in a hospital. But when given bias model predictions, clinicians' diagnostic decisions were severely harmed. So we had an over 10% drop in diagnostic accuracy. This is really bad. This is a lot of patients who are receiving incorrect treatment and have an increased likelihood of mortality. And then when given explanations, they just didn't help clinicians recover to baseline. So again, these explanations were overtly biased. Even with this, we only had a very slight recovery, and this recovery wasn't actually statistically significant. The confidence intervals here overlapped with clinicians with the bias model alone. So explanations didn't help in this case. In addition to this, we also grouped the analysis by provider type. So we looked at whether or not the participant was a nurse practitioner, a physician assistant, or a physician, that's someone with an MD. And given systematically biased models and then given explanations, again, we found the same trend in the nurse practitioner and physician assistant group, as well as the physicians. So those, again, with MD. So even when we subgrouped by the provider type, it didn't really matter what the provider type was. They were still hurt by these biased models, and the explanations didn't help. And then we also grouped the participants by whether or not they had interacted with AI before in their clinical practice. So this was kind of a proxy for, what is this participant's AI experience? And again, by subgrouping by interaction with AI, we found the same thing. So if they did have prior interaction with clinical decision support, no change in the trend. If they didn't have interaction, again, no change in the trend. So even when we split the data this way, there wasn't really a subgroup of participants who were helped by the explanations. So then we looked at treatment accuracy. Again, it's one thing to make a diagnosis. It's another thing to actually give the patient the wrong treatment and then ultimately harm patients at the end. So again, given the clinician alone, their accuracy in terms of treatment was about 70%. And then when given a correct model, so when the AI gets it right, clinicians make better treatment decisions. So significantly better. We had a 7% increase in accuracy. And explanations amplify this effect. So even more, we had a 10% increase in accuracy. This is really good. This is what we'd want to see. But then when given incorrect models, and when the AI is wrong, clinicians fail to make the correct treatment choices. So we had a 15% decrease in participant accuracy. This is a very big drop. This is not something we want to see in the hospital. And then when given explanations, again, they don't remedy this effect. So they didn't really recover. The confidence intervals overlap with the incorrect model alone. So again, even with treatments, the explanations didn't really signal anything to the participants. Okay, so overall, explanations that were overtly biased didn't help. And we had similar results in our subgroup analyses as well, which are in our paper. But what I didn't mention was that we actually had a ninth vignette. And this ninth vignette was a clinical consult And what I meant by this is we presented a vignette with a clinical consult from a trusted colleague. And so we told them a trusted colleague is giving you a diagnosis for this patient. This is what they think. And the goal here was measuring an upper bound on clinician performance when given any assistance. So the clinical consult looks something like this. We said a trusted colleague who saw this patient wrote in their consult note, here's what I think the patient has. And here it says, I think heart failure is very likely the underlying cause of her acute respiratory failure. I would recommend aggressive diuresis. So they gave both the diagnosis as well as the treatment. And this note was always 100% accurate. So the hope was that we could get some insight as to, if we gave participants a completely accurate model, how well are they going to do? And this gives us an upper bound on kind of what we should be aiming for in terms of participant performance when interacting with an AI. And so again, as a reminder, in terms of clinicians' diagnostic accuracy alone, they are about 73% accurate. And with the standard model and explanations, they reached almost 78% accuracy. And then given this clinical consult, clinicians were about 81% accurate. So they left about 20% performance on the table. And this, they just performed still less than perfect, even when given completely accurate advice. And this is really insightful because it kind of just points to the fact that this diagnosis is very difficult and clinicians often disagree with what the patient's diagnosis is. So we have this upper bound on participant accuracy, and we actually get really close to it when we give them the standard model with explanations. So even, their other work might look at, how can we raise this upper bound in terms of clinicians' performance, but we get pretty close with our standard model and explanations. Okay, so we have some hypotheses as to why clinicians didn't catch bias in this setting. And one of them is heat map explanations can't communicate in plain language to clinicians. So when a clinician goes to a clinical colleague and says, hey, what do you think this patient's diagnosis is? The colleague can tell them, I think it's pneumonia because, and then give them an entire explanation for why they think the diagnosis is what it is. And so model predictions here might be more helpful if we present them differently. Instead of presenting a heat map, we might have a text explanation. We still don't have tools to do that, but that could be something that AI researchers might aim for in terms of, developing better explanations for clinicians. In addition, clinicians were only shown a small number of vignettes with their explanations. So in total, they saw 9 vignettes with explanations. They only saw 6 vignettes. And so they might just need more training with AI explanations. The majority of our participants, so I think it was about 73% of participants, had never actually interacted or said they didn't interact with clinical decision support before in their clinical practice. So this might just be new to them. And even though we gave them kind of an introduction to what are explanations, here's what they might look like, they might just need more training with the explanations. And then finally, only 23% of our participants were actually aware that AI models could be biased. And so if you don't know what you're looking for, it's kind of hard to detect inaccuracies in AI models, and that might be going on here. So perhaps informing clinicians of AI strengths and weaknesses could better equip them to leverage AI explanations because they know what to look for. They would know that, like, hey, something outside the lung region is probably irrelevant. Maybe I shouldn't pay attention to this AI. Okay, so what are some next steps that we think might be useful in terms of integrating AI into healthcare? So we had some pretty promising results in terms of our standard model, and even though the bias model didn't do too great in terms of hurting clinician performance, we still want to think about next steps in terms of integrating AI into healthcare. One might be incorporating AI into medical training. So right now, the majority of participants, again, don't really know how to interact with clinical decision support tools. And AI is not incorporated into medical training, so during medical school at all. But as AI becomes more and more present in the hospital, it might be helpful to very early on teach clinicians how to leverage AI in terms of their clinical care. Additionally, something researchers might think about is more diverse collaborations. In our work, we worked with human-computer interaction experts. We were working with radiologists, with pulmonary physicians. But that's not actually the case in most settings. So a lot of the times AI model developers are developing AI tools for themselves rather than the end users. So really thinking about developing more diverse collaborations and really understanding what do doctors want in terms of their AI tools, and continuing that conversation might be more helpful. And that could in turn inform policy decisions, because oftentimes policy decisions are leaving someone out of the discussion. For example, maybe whoever proposed the policy about AI explanations to the FDA wasn't really aware that there wasn't much research on AI explanations to begin with. So just encouraging more diverse collaborations between AI model developers, human-computer interaction experts, as well as clinicians and patients. And then finally, continued model validation during development. So just because we know this bias exists and we're hoping that clinicians can catch the bias at the bedside doesn't mean we can't keep trying to work on just continuing to debias models during development using computational approaches. So that means lots of subgroup analyses, understanding how it does on different patient populations. Development and deployment or validation at external hospitals might be helpful. Just kind of having a robust toolkit in terms of development can make AI model developers more confident about actually deploying AI into hospitals. So that's the end of my talk. The overall, overview is current explanations just aren't a good stopgap in terms of helping clinicians catch bias. They might just need more training with AI, and then we need more approaches and more explainability tools to understand models.